So welcome med geniuses to another lecture series today. So we'll be talking about neurological assessment. So this playlist is just about neurology assessment, how you assess a patient that has any brain damage, or even though not brain damage, a patient just have a recent trauma and you want to assess whether he's alert and responsive, or he's conscious, or any part, or it could be motor function, sensory function, vital signs, the proprioception, many stuff. So in this playlist we'll be talking about all of them in this neurological playlist here. But here we'll be starting with what we call the glycoscoma scale. The glycoscoma scale, so we call it the GCS. Are you getting that? The glycoscoma scale, GCS. So that is the first topic we'll be starting in our neurology playlist, or we call it the neurological assessment. So in neurology there are so many parts. We're talking about some disease too, some assessment parameters, what you should know, even clinical case studies. We'll be talking about all of them so in this playlist. So but for this one I want to just start with GCS, because it's very important to know how to detect a patient level of consciousness. So when you come to a patient, you want to know whether it's alert and responsive, whether he knows, because this will tell you everything about the person's neurological status. Are you getting me now? So I want you to stay to the end of this video, because you'll learn a lot. And if you are just new to my channel, make sure to subscribe and turn on your post notification button, so at any time I drop any video you'll be sure to be notified. If you want me to make a video for you, drop it down in the comment section. I promise I'll make that video for you. So I want you to listen to the end, because I'll be giving you cheat code and be doing some examples to dictate this GCS and how you can apply it to every patient. And remember, it's not only GCS you can use. There are so many parameters to check a patient level of consciousness, which we'll be talking about in other videos. We'll talk about it, but this one is primarily GCS. But in another video I'll make another video and give you other parameters you can use to check a patient level of consciousness, because they are different. This one is just used to check a patient level of consciousness that is in maybe in the ward, like is not in ICU or after surgery. No, it's a patient that is in a subacute state. Again, in a subacute state, not a chronic state, not all those states. It's just a patient that's already subacute going to recovery. So you want to check. Let us jump right into the video. So the first question we'll be asking ourselves: what is glycocoma scale? What is glycocoma scale, or call it GCS? So like I said initially in my presentation, I told you that it's a neurological assessment tool. First of all, it's a neurological assessment tool. We use it to assess the neurological status of a patient. So it's a neurological assessment tool used to evaluate the level of consciousness. Used to evaluate the level of what consciousness is usually used primarily. So there are so many that AVPU can be used. You can use the Richmond assessment scale. You could use many. You could use a 4-point scale. There are so many scales you could use, but the one that they use majorly during trauma triage, when you just bring a patient, admit a patient, or after surgery, the one you use primarily is the GCS. That is the one that is being used currently. So it's a neurological assessment tool used to evaluate the patient level of consciousness. But I told you there are so many tools you can use, but the one that is rampant and that people use majorly is the GCS. It helps you determine the severity of a brain injury and what guide treatment and monitor progress. So it helps you to know how much the brain is already injured, because when the brain is injured, it affects some physical functions of the patient, because the brain is just like a central system that controls every part of the body. So when any part is damaged, it will affect every part of the body. So now in glycocoma scale, you have basically 3 components we are using to check here. We are using the eyes, we are using the verbal response, and we are using the motor response. So we are using the eye opening, so you check whether the patient eye is open. You are using the verbal response, and you are using the motor response. So I'll give you how to assess the patient on all these things, so it will be a step at a time. So very, very easy. So just check what I'm showing you. The GCS score is between 3 to 5, which you have seen. So your eye opening is 4 points. Your verbal response is what, 5 points, and your motor response is 6 points. So when you remember EVM eye opening, verbal response, and motor response, 4, 5, 6, and the GCS score is between 3 to 15. So again, always remember it's a neurological assessment to use to check and evaluate the patient level of consciousness. So when you want to use it, you want to determine the extent of the brain injury. You want to use it to guide treatment, because you can use it as an functional outcome measure. Outcome measure is that you use when the patient entered, maybe his GCS was very low, like 3. He was unresponsive when he was brought in. Then after maybe a treatment for about a week or so, maybe 7 or 8 or 9 treatment section, you evaluate his GCS again to check whether you are doing the right thing or you are not doing. So it's used to evaluate, guide treatment, and to check monitor progression. You get it now? So now, what does the GCS score means? What does it mean, and what does it tell you when you are looking at the Glasgow Coma Scale? What does it tell you? Number one, between 13 to 15, which shows that the patient has a mild brain injury, which means the brain injury is not that much. So it's a mild brain injury between 13 to 15, which means so if they tell you a patient GCS is 13, 14, 15, which means he's responsive. Are you getting now? So there's the brain injury is not that severe. So the patient is alert already. Now, if the GCS is between 9 to 12, it shows you a moderate brain injury, but there's significant impairment here. The patient has significant 1 or 2 impairments. Maybe they could be focal, but not generalized deficit. Maybe 1 or 2 deficit at start when he or she came in. And when it's between 3 to 8, that means there's severe brain injury, which means the patient is critical and he might be comatose. Are you getting now? It might be comatose. So again, always remember, between 13 to 15, mild brain injury; between 9 to 12, moderate brain injury; and between 3 to 8, severe brain injury. So where do you use GCS primarily? So it's using emergency medicine and trauma. So you can use them when they bring in a patient, or when maybe you are triaging patient, or the ambulance just brought in any patient into the emergency ward. So what happened? First of all, the paramedic will always give you the GCS. So when he or she was seen, what was the GCS at that point? Because it will tell us so many things. If the GCS is at 3, which means we're supposed to be administering fluids, we're supposed to be giving, we are supposed to make sure he's on oxygen throughout. But when the patient is about 13 to 15, which means a mild brain injury, which means it doesn't call for alarm, even though we might not administer oxygen at that point. But when it makes you differentiate between critical patient and a non-critical patient. So it's used in emergency medicine, especially in trauma. So it's used in neurology and neurosurgery, especially when you want to determine whether it's a focal or generalized neurological deficit, or maybe I want to determine whether a patient needs surgery, or maybe you have any hematoma in the brain or anything. So GCS is used also in the intensive care unit, in the ICU. Okay, maybe a patient just undergone a brain surgery, or a patient just undergo any surgery, maybe cardiac or general surgery, and is already in ICU. You must always, because you don't know the extent to which the patient's blood loss will have affected him or her inside the ward. So it's also used in ICU. So it's also using stroke assessment, because we also do stroke in some of our videos. So it's also using stroke assessment. And it's also used to monitor changes in unconscious patients. So patient that came in maybe unconscious with GCS of 3, and maybe you have to monitor maybe as at when the patient wake up, so you compare and contrast what happened at that particular point in time. So the next one, I want to talk about the individual components of the GCS scale, the individual components of the GCS scale, and how to assess them. So the first one here we are doing now in deep dive assessment of the eye movement. The deep dive assessment of the eye opening. So first of all, EVM, don't forget eye opening, you have verbal response, and you have motor response. So the first one here is the eye opening. Now here we want to assess how well the patient can open his eyes in response to every situation. So you want to check how much the patient can open his or her eyes in response to the stimulus around the patient. because it's, remember, the Brodmann area that carries sense of seeing or eyes is, or sense of vision, is the area 17 in the occipital lobe. The area 17 is the primary visual cortex, which carries what, sense of what, vision. While the primary eye field, which is located in area 8 in the frontal cortex, carries what, visual eye field, your eye opening, conjugate eye movement. So here you are testing for the area 8 in the frontal cortex and area 17 in the occipital cortex. So that's what you are doing here. I told you that it is calibrated from 1 to 4. It is calibrated from 1 to 4. So what is 1? What is 1? No eye response. Maybe the patient came and the patient has no eye response. I get him now. The patient has no eye response. So despite you inflict pain, maybe you get it now, you inflict pain to the patient. A pain can be applied in so many directions. The pain can be applied on the nail bed. Maybe you put a pen on the nail, or you put any hard object on the patient's nail, like fingernails, and you press it on it, and the patient did not see open his eyes. Or you squeeze the patient nipple if he's a man and the patient did not open his eyes. Or you use your knuckle, I get your knuckle, your interphalangeal joint, you use it to press on the sternum and the patient did not see open. So that is eye opening. That is number 1. Number 2, now maybe you inflict pain on the patient and the patient open his or her eyes. So now if you inflict pain on the patient, or you shout the patient name, he or she doesn't open. First one, you go to the, maybe you are doing your rounds, or the patient came in and you shout, my name is, you introduce yourself and you are talking and the patient's eyes is still closed. Then when you are done and you inflict pain, the person's eyes doesn't open, that's 0. But when you inflict pain, the patient opens his or her eyes, that is what, 1. So inflicting pain, I get him now, gives you a 2. I get him now. But when you inflict pain, the patient doesn't open his eyes, that is a 1. Inflicting pain, opening eyes, 2. Inflicting pain, not opening eyes, 1. Are you getting me now? But when you talk, if the patient can open his or her eyes to your speech, maybe you introduce yourself. Do you know where you are? My name is so. Do you know where you are? Do you know what happened? And the patient open the eye, immediately hear voices, which means the patient can articulate voice. Are you getting me? The patient can articulate and understand. And you open the eyes due to that stimulus, you give the patient a 3. So 1 is in presence of speech and pain, there is no response, 1. In presence of pain, there was a response, 2. In presence of only speech, the patient opened his eyes, 3. So if you say open your eyes, or what's your name, and all this, and the patient opened eyes, 3. And the last one, that in you talk, or you met the patient and the patient's eyes was already open. I get him now. The eyes was open naturally. You give the patient a 4. I get him now. You didn't have to inflict pain. You just came into the ward and you see the patient and you're conversing the patient, and the patient has good eye movement in all directions, and you move all around the bed and the patient also is still opening his or her eyes. You give the patient a 4. I get him now. Like I said, you can inflict pain. When you inflict pain or you talk and if the patient doesn't open the eye, you give the patient a 1. That is E1. If you inflict pain, are you getting that? So how can you inflict pain? I told you can inflict pain by putting a hard object on the nail bed, apply a pressure there, or you do a sternal rub. And what is a sternal rub? I told you, putting your knuckles on the patient's sternum and you press against and you hold it on the patient's chest, and the patient do not open, so you use it to assess. If the patient open, you give the patient a 2. Apart from nail bed and sternal rub, you also have supraorbital pressure, applying pressure on the above the patient eyes, so you'll be seeing the picture of supraorbital pinch or pressure on the supraorbital region. Or you do a trapezius pinch. A trapezius pinch is holding the trapezius muscle and pinching it. Open the trapezius muscle and pinch. So it will feel 1. So 1 is either you are putting pressure on the nail bed, or you are applying a sternal rub on the sternum, or you are putting supraorbital pressure above the orbit, or you are putting a trapezius squeeze. So when you squeeze the trapezius, the patient, or you all just squeeze the nipple, or you squeeze the nipple for a man, but for a woman you can also, I don't know how legal that is, but you can also inflict pain but like that. So if he open his eye, you give the patient a 2, but if he doesn't open his eyes, you give the patient a 1. So to speech now, you can say, can you hear me? What's your name? Can you hear me? Or you ask the patient, command the patient to open his eyes, or you ask the patient, what's your name? Can you hear me? Or open your eyes, you give command. If the patient can open his eyes, you give the patient a 3. Now if you already the patient eye is open when you came there, you give the patient a 4. So this is how you can assess what eye opening. The next one is verbal response. In verbal response, what happens? You want to assess the ability for the patient to what? To speak. Are you getting now? To speak, to understand you and to speak. To understand you and to speak fluently. Now, for I told you in eye opening, what you are testing for the area 17, which is on the occipital cortex, which is the primary visual cortex, and you're also assessing for your area 8 too, which is at the that is the primary eye field, which is at the frontal cortex. But here now in verbal response, what are you assessing? You are assessing your Wernicke's area 22, that is the auditory association cortex, and you are also assessing the area 44, 45, which is the Broca's area. So you are assessing the Wernicke's area and the Broca's area to see whether the patient can understand, which means the Wernicke's area is fine, and whether the patient can express him or herself, which means the Broca's area is good. So you are assessing area 22 and area 44 and 45 here. So now, first of all, what do you say now? Now, if it's first of all, you come, you talk to the patient, and the patient is maybe closing his eyes. The patient cannot speak. He's closing his eyes or is opening his eyes but cannot speak. No verbal response. Or you ask, what's your name? Where are you? And all this stuff. You ask the patient, do you know why you are here? Do you know what happens to you? And the patient cannot reply you. You give the patient a 1. Remember, if you talk or you apply pressure to the patient and he did not open his eyes, you give the patient a 1. But if you also talk to the patient or you apply pressure and the patient cannot speak back to you, give the patient a 1. So no sound, even after pain stimulation, the patient too cannot give any sound. He cannot even cry, he cannot say anything. Give the patient a 1. Now, incomprehensible sound, maybe if the patient is giving incomprehensible, maybe moaning, groaning, or mumbling, maybe due to pain. So maybe the patient came in, it also can suggest to you that maybe the patient is in pain. The patient might be having some inflammatory pain at that particular point. It could be inflammatory, it could be neural pain, it could be any pain that is just maybe is moaning or something is making him shout. It could also be, it could tell you the neurological status, maybe a psychiatric issue or anything that is causing the patient to speak in incomprehensible sounds. Then you know that you give the patient a 1. Are you getting that? For incomprehensible sound. So if the patient is giving inappropriate words, now inappropriate words is that you came inside and your incomprehensible sound can give you that pain. It can suggest pain to you clinically, or maybe mental issue. That's one could give you a 2. Now, but inappropriate words can be also told you that there might be issue with the prefrontal cortex. Maybe he cannot articulate words very well, or the words he's saying is not, he could be having expressive aphasia, Broca's damage, incomprehensible sound, random and unrelated sound. Maybe you ask the patient, where are you? Do you know where you are? Do you know what happened to you? And the patient is not talking about a giraffe or a hippopotamus, or he's talking about random stuff, random numbers. It could also suggest a psychiatric issue. Are you getting now? So incomprehensible. First one is what? In no verbal response. 2 is incomprehensible sound. Are you getting now? 3 is inappropriate words. 4, and the patient is confused. Are you getting now? The patient is speaking, but the patient do not know what he's saying. He's just saying, now it's not inappropriate words, it's different words that are not tallying. Are you getting now? So, but in confused conversation, for you to give the patient a 4, maybe you ask the patient a question and he's saying, I think I'm at home, I don't know what the day is, and all those words. He's making sentences, but the sentences are not tallying. The patient is confused. You give the patient a 4. But if the patient say, but a, ash, star, all these words, you give the patient a 3. Now if the patient is oriented, maybe you ask the patient all question and he answer you very well. You say, what's your name? He say, I am John. Do you know where you are? I'm in the hospital. Do you know what today is? Today is Monday. If the patient can answer you very well, give the patient a 5. So the question to ask here to elicit this verbal response is, okay, what's your name and do you know where you are? Are you getting now? What's your name? Do you know where you are? Do you know what today's date is? And do you know what happened to you? You get it now? So what's your name? Do you know where you are? Do you know what happened to you? Are you getting now? What's today's date? If the patient can give you correctly, you give the patient a 5. Are you getting now? And here you listen carefully to the patient's response and score the patient based on the response elicited. Are you getting me? And if there's no verbal response, you can also apply pressure and reassess. Are you getting me now? So this is very, very important. Are you getting me now? This is very, very important. But now also you should also know that this exception also goes for patient in ICU that is intubated. If a patient is intubated, the patient, you can only score the eye response, but you cannot score the verbal response. And if you cannot score the verbal response, you can also use the 4-point scale. Are you getting now? Okay. If you cannot score the verbal response because the patient is intubated, you can put what you call T in place of that verbal response. You can put T there. So you can also only record for eye movement, eye opening, and motor response. Eye opening, motor response. For the verbal response, you put a T there. For the verbal response, you put a T there. Or you tell the patient to do a gesticulation. When the patient do a gesticulation, maybe, or write down as the patient is hooked onto a tracheostomy tube, you can also reassess from there. So remember, in patients that have a tracheostomy tube, a tube attached to the trachea, you can also put, instead of the verbal response, you put a T there. Are you getting now? So that's it. So the next one is the motor response. Are you getting now? The motor response. The motor response is the other one, which is the last one. Remember, 1 to 4 is the eye opening, where first of all, when there's no eye opening, even though you apply pain or you speak, no eye opening, you apply pain, the patient opens his eye too, you are speaking to the patient, and when you talk, the patient opens his eyes, that is 3. If the patient opens his eyes before you come, or through the conversation the eye is open, so just 4. And you're using it to access for the area 8 in the frontal cortex and the area 17 in the occipital cortex. Now in the verbal response, now you are giving from 1 to 5. First of all, no eye opening, no verbal response, you give the patient a 1, and you can use it to assess for the area 44, 45 with the Broca's area, and the area 22, which is the Wernicke's area. So now 1 means no verbal response, even when you apply pain, when you talk to the patient, no verbal response. Then 2 is incomprehensible sound. You cannot know, it could suggest that the patient is feeling pain. Inappropriate words, the patient is just throwing out words that are not making sense. Not even if the patient is not confused, but the words are just unrelated, you give the patient a 3. If the patient is confused, saying different things that are not tallying, you give the patient a 4. And the 5 is that where the patient can answer all your questions. So for motor response, now how can you assess motor response here? Number 1 means that there's no motor response at all. And now what area of the brain are you using this for? You are using this to check for the area 4 and area 6. Area 4 and area 6. Yeah, area 4, area 6, area 3, 1, 2 also. Area 4 is the primary motor cortex. Area 6 is the supplementary motor cortex, or the premotor areas of the brain. While area 3, 1, 2 is the primary somatosensory cortex. All these are located in the front and back of the central sulcus of the cerebrum. So we'll also be doing all those parts. So you go watch my video on the Brodmann area of the cerebrum in my neuroanatomy playlist there. Yeah, so you have to know all this thing very well. So first point means no motor response. When you apply pain, you talk to the patient, and there's no motor response, you give the patient a 1. You get it now. So number 2 is that they have abnormal extension. We call it decerebrate posturing. Decerebrate posturing, which means the arm is extended, the wrist is pronated, and the leg is extended. So if you meet a patient like this with everywhere extended, are you getting when both the hands and leg are extended, when you meet the patient, it is showing that the patient is having decerebrate posturing, which is abnormal extension, which means there's loss of the cerebrospinal tract, which is the reticulospinal tract, and the vestibulospinal tract are much more active. Are you getting now? So the patient is having overstimulation of their reticulospinal tract and vestibulospinal tract more, so they are usually much more extended throughout the reaction. You get it now. So the corticate, the cerebrate posturing, abnormal extension too. And even though when you apply pain, the patient is moving the hands out, you are applying pain to the patient, and the patient is, instead of the patient to come towards the pain, the patient is extending itself. You see the hands are going out in extension, the legs are going out in extension. That is abnormal extension. You are talking about the descending tract, which is the reticulo and the vestibulo, overstimulation of them. Number 3, you give the patient abnormal flexion, the corticate posturing, which means the corticate posturing abnormal flexion is when there's overstimulation of the rubrospinal tract, which means the lesion is spares the lesion spares the midbrain. So the lesion is below the midbrain. Are you getting that? No, the lesion did not affect the midbrain. So if the lesion doesn't affect the midbrain, the red nucleus is still active, which means the rubrospinal tract will be overstimulated. And anytime the rubrospinal tract is overstimulated, you're having what? Flexion. I get him now. So when you are applying pain to the patient is flexing. Not that the patient is coming to the site of pain. The patient is only flexing his upper limb very well. Flexing his upper limb, which means the red nucleus is active and the rubrospinal tract and this decussation is also active. But when the patient is having and the cerebrate posturing, which means the lesion didn't affect the brainstem, the lesion didn't affect the pons and the medulla. Are you getting now? The lesion didn't reach there, which means those places are overstimulated and the lesion was above the midbrain up. The lesion was affected the midbrain and the cerebral cortex. Are you getting now? But if you have the corticate posturing, the lesion was only affecting the cerebrum. Are you getting at the cerebral hemisphere? It didn't touch the midbrain, pons and medulla. Are you getting that? It didn't affect the midbrain at all. But if it affected the midbrain down to the cerebral cortex, that means the patient will have the cerebrate posturing. Yeah, you have to know the reason why there's the corticate posturing and the cerebrate posturing. So what if now you apply the pain and the patient is moving their hand from pain? Maybe you apply the pain on the knee bed, or you apply the sternal rub, or you squeeze the nipple, or you do a supraorbital pinch, or you apply a trapezius the trapezius pressure there, and the patient is going towards that area or moving his body from that area. So you have what you call withdrawal for pain. You give the patient 4. So no response 1, abnormal extension, which is the cerebral posturing, abnormal flexion, the corticate posturing, withdrawal from pain. You give the patient a 4. Now if the patient can localize the pain, what's localizing the pain? You are doing a sternal rub, or you are doing a trapezius pinch. Are you getting now? You are doing a trapezius pinch, or you are applying pain in any direction, and the patient is coming towards that area. Are you getting me now? The patient knows he's having pain there, and is coming, maybe a sternal rub, and the patient is trying to put their hand on the sternum. Are you getting me now? To now remove your hand from the sternum. Are you getting me now? Which means the patient can localize. So you should know the difference between withdrawal. Withdrawal is that the patient will move away from that pain. And if you are not doing, if for the person to localize the patient, for anybody, some people can withdraw away with fast, like they remove their hand or try to remove themselves from that place, or why some people we try to put their hand towards that area. Maybe if I'm applying a pressure on the knee bed on my right hand, is now bringing his left hand towards that side. So what you are doing is what the patient is localizing, and when the patient tries to localize the pain, you give the patient a 5. And if the patient obeys command 100%, if the patient obeys command, you give the patient a 6. Are you getting me now? Obey command means show me 2 fingers. The patient open 2 fingers and show you, shows that you give the patient 6. So how can you assess the patient? Ask the patient to open their eyes. If the patient open your eyes, so just tell the patient to squeeze your fingers. Put your fingers there and let the patient squeeze it. Are you getting that? So if the patient can squeeze their fingers, which means the upper limb is fine. Squeezing your fingers is not just number 1. If the patient open his eyes and the patient say, do you know where you are? You ask for the patient and the patient give you a verbal response. I say, squeeze my finger for me. If the patient can squeeze the finger, which means the upper limb is fine, I tell the patient to move their legs, and the patient can also move their legs, which means the lower limb is also fine. I get it now. But if the patient cannot obey command, always apply pressure. If you apply pressure or pain stimulus, it can also give you the response you want. Are you getting me now? So always know what is the corticate posturing. The corticate posturing is the flexion of the upper limb, which show you that there is overstimulation of the rubrospinal tract, which means the lesion is Are you getting me now? It's above the midbrain, which means only the cortex, the midbrain, the pons, and the medulla are spared. Because now the lower limb will be on extension, telling you about the reticular and vestibulospinal tract overstimulation, and why the upper limb, which is the upper limb, will be flexed due to the rebospinal tract in the midbrain, from the midbrain. Now if the patient is, everything in the patient's body is extended, this shows you that the patient has what overstimulation of the reticulospinal tract and the vestibulospinal tract, coming from the pons and the medulla, which means the area of damage is above the midbrain. So above the midbrain, in the sense of the midbrain is damaged together with the cortex. So the midbrain is damaged and the cortex is also damaged. But the first one, the midbrain is spared. Are you getting me now? The midbrain is spared. So in these two cases of the cerebrate and the cortical posturing, the pons and medulla are always spared. The pons and medulla are always spared. The only one that dictates is either the midbrain is damaged or the midbrain is not damaged. If the midbrain is damaged, there will be overstimulation of the pons and the medulla. But if the midbrain is not damaged, you have all you have deflection and the extension posturing all the time. I get it now. So ways you can apply pressure, I told you at the beginning. You can apply supraorbital pressure, which I've showed you in this picture. You have the trapezius squeeze. You apply pain pressure on the knee bed, and you apply sternal rub using your knuckle to press on the sternum. But don't apply too much. Don't apply too much, because it can cause when you don't apply too much, because so that you not damage the underlying tissue, because that will be bad. Okay, now, so to summarize all my interpretation and we'll also do an example too, you should know that 13 to 15 shows you that the patient have mild brain injury. Are you getting now? Mild brain injury, the patient is fine, alert and oriented in the field. So for you to get that 13 to 15, which means the patient will be conscious, that is number one. The patient will be oriented. The patient will have mid confusion, mid confusion, and the patient will have short-term memory loss. So for you to have this mid brain injury, which means now what you have to do, clinical action, you have to observe, monitor, and give what we call supportive care. If the patient have a 9 to a 12, which is moderate brain injury, there's also just significant impairment at that particular point, which means the patient will be drowsy or confused. Are you getting me now? Drowsy or confused, you know what it gives you when you are doing your verbal response, is giving you like a 4 there, and the patient will be disoriented. Are you getting me now? The patient needs assistance, and there's a risk of deterioration if you do not act fast. So give a close monitoring, investigate, and know the underlying cause of why the patient is between a 9 to a 12. Now if the patient is 3 to 8, which means the patient is critical and maybe in comatose, but not abject comatose or vegetative state. Maybe the patient is just have fainted or has just been there. So what you do, the patient is unconscious, no meaningful response. I get him now, and mid risk of complications and required intensive care. So you have to make sure the airway is protected by putting oxygen, and you have to make sure the patient is given an ICU care and an urgent treatment. So don't forget, 3 to 15 is the score. 1 to 4 for eye, 1 to 5 for verbal, 1 to 6 for motor. And always remember, you have to assess the eye movement, the eye opening, the verbal response, and the motor response in that order. Use the best category in each. Use the best response in each category. And if the patient is on the tracheostomy tube, instead of the verbal response, you always put a T there. You substitute a V for a T. Are you getting now? Now, I've given you where GCS is already used already. Now for the example, now let us say a patient has open his eyes to speech. Maybe you talk to a patient that, hey, how are you doing? My name is so. Do you know where you are? And the patient open their eyes. Terry, give the patient a 3. But when the patient start talking, the patient was confused. You give the patient a 4. And when you apply pain on the patient withdrawed from the pain, you give the patient a 4 also. So when we plus all these 3, we are getting 11, which means the patient has a moderate brain injury because of that confusion there, and the patient couldn't localize the pain. The patient only withdrew away from the pain. The patient couldn't localize the pain. So you give the patient an 11, moderate brain injury. And what should you do for moderate brain injury? You know the underlying cause of the moderate brain injury, and also you give a close monitoring. You get it now. So now For why it is clinically important for us here as medics is that you have to assess the level of consciousness before you start treating. It helps you to monitor changes over time. Are you getting now? So you can dictate a patient that is improving or a patient that is deteriorating, because if the GCS at the time of admission is 13 and after some time the GCS go down to 9, which means there's still a problem. So you have to check for the underlying cause. Now it also guides treatment decisions, and determine the ones that is urgent and the one that is not urgent. And you have to know the level of care, the one that you have to triage, to know the one that is good. Start from the one that needs urgent need to the one that doesn't need urgent need. Are you getting now? Right. So the lower score gives a worse prognosis. The lower score gives a worse prognosis. Are you getting now? So I hope it all makes sense to you and you have understood everything I've talked about here about the GCS. So hope you understand. Are you getting now? Remember that the GCS is what? The eye-opening EVM, eye-opening verbal response, and what? Motor response. 1 to 4 for the eye-opening, 1 to 5 for the verbal response, 1 to 6 for the motor response. And the Glasgow Coma Scale is a simple yet a powerful tool used by healthcare professionals to determine what brain functions and the ones that need urgent, and to know the level of care that you can give to a patient, and also monitor progress. Are you getting now? So if you are still here up to this time, make sure to subscribe to my channel, and also like and put a comment, because it also helps us make more videos. Are you getting me now? So subscribe, share it to all medical students that will need this video, because when you are about to assess a patient, you always have to check the patient level of consciousness. It's very, very important, because you have to determine if it's something, if you are still an intern, or you are still starting, or you are still a student, medical student, or you are still a medical student. What you just have to do is that when you see that it's alarming between 3 to 8, you have to call your superior. So I'll be seeing you in my next video, or continue watching my video and continue sharing. Bye bye.